The last couple of days have seen perhaps the biggest hope that we've seen in months since this COVID crisis affected the entire world. There's been a lot of progress as far as the vaccine candidates are concerned, and now there are a clutch of vaccine candidates which will soon be available. The question is when, and the question is, do they work and are they safe? Principle in deciding or giving an opinion on where these vaccines can really have an impact is the World Health Organization. Joining us now, Dr. Soumya Swaminathan, Chief Scientist at the WHO. She joins us from Geneva. Thanks very much for being with us. Are all of the vaccines which have been spoken about recently, Moderna, Pfizer, AstraZeneca, are they safe?
Hello, Vishnu. Thanks for that question. It's a really important one. And of course, what we know about these vaccines is what's been released based on the interim data, that interim analyses that these companies have performed and released to the public. The complete data set will be submitted to the regulatory agencies as well as to WHO for pre-qualification, and that's when we get to see all the data, including the safety data. So far, there don't seem to have been any major safety signals in any of the trials that we've seen results from. But on the other hand, we have to remember that the follow-up is really, really short. You know, these trials all began July, August onwards. So by the time participants were enrolled and received 2 doses of the vaccine, they've had a follow-up of 1 to 2 months max. And that's really not enough. And the numbers are also relatively small. So I think what I'm trying to say is that we need further follow-up. We need more data. And we have to be open about both the efficacy and the safety data as they're coming in. We've seen just the tip of the iceberg. There's a lot more data really to explore from each of these trials.
Dr. Swaminathan, the Oxford vaccine candidate threw up something interesting that if there was a part dosage, then it seemed to be far more effective once that second dose was given. Why is that the case, and does the fact that we don't really know very much about why that is the case concern you?
Well, first of all, I would say that, again, it's based on very small numbers. So the AstraZeneca data that was released was 2 different trials, and it's quite unconventional, really, to have combined these 2 different trials and then come up with one efficacy estimate. That's not the way it's usually done. So the one trial looked at the half dose followed by the full dose, and the other trial is looking at 2 full doses. And it's the half plus full dose was less than 3,000 participants. So with the total number of infections as well in that group being relatively limited, it's very hard to really compare the small group of 3,000 people with about, I think, 8,000 and odd people in the other group. These are really small numbers. So the first thing I would say is we need more data again on larger groups of people to first find out whether there was really a significant difference between these 2. You can get these things by chance as well. The second, if it is true, then there are hypotheses. I mean, hypotheses include the fact that the slower dose acts as a priming to the immune system, activates the T cells, and then you come in with a bigger dose and you get a strong immune response. It could also be that because this is an adenovirus, the body starts producing antibodies against the adenovirus as well as against the spike protein of the SARS-CoV-2 virus. So giving a smaller dose might actually result in lower antibodies being produced by the body against the adeno part of the vaccine. So these are hypotheses which need to be explored. So at this point, it's just sort of informed guesswork. One can't be sure.
Dr. Swaminathan, how safe are these for children from the very onset?
Well, most of these vaccines have not been tested in children. So they started with 18 plus. Generally, these trials are always done in adults first because of obvious reasons of safety and also the ease of doing trials. And then usually companies go down. So some of the companies have started going down below 18. So the next age group is 12 to 18, and then they would go further down. So that question cannot be answered at this point for any of the vaccines. We don't have data in children.
How realistic would it be to have something like the Moderna drug or the Pfizer drug be shared with countries like India or nations in Africa, given the requirements for temperature that they have?
Yes, I mean, that's a really important point. The mRNA vaccines, both Pfizer and Moderna, are these new type of vaccines, which are based on mRNA technology. They have the advantages, of course, of being very quick to manufacture. But on the other hand, because of the nature, because of the instability of the product, the Pfizer product needs a minus 70 degree storage condition and the Moderna at minus 20. So this actually creates some logistical difficulties for many, many countries, including high-income countries, which don't necessarily have minus 70 storage facilities, down to their small towns and villages. So this is going to be a challenge for all countries, particularly, of course, for the developing world. And the companies are coming out with some innovations, alternatives to minus 70 freezers using dry ice storage containers. But that, again, means that you need to have enough dry ice replacement capacity to keep it cool enough, and it lasts for about 5 days, and then you have to keep replacing it. So I would say it's possible to use these vaccines perhaps in big cities, in metros, where these facilities either exist or could be created, and it could be used to vaccinate, say, very high-risk groups, like the healthcare workers working in big hospitals and so on. But it would be very challenging to go beyond that,
right,
and take it down, to the district and lower levels.
A final question: are you convinced about mRNA vaccines coming online now? The science.
Am I concerned about the science?
Yeah, well, it's new technology. It's an approach which has not really been followed in the past. Do you have concerns on that? On the science, the fact that it's very new, the fact that we don't have very much experience, or are you convinced of what you're seeing?
First of all, let me say that it's amazing that this has happened, okay? Within a matter of 11 months since the new virus was discovered, the mRNA vaccines went into creation just a couple of hours after the whole genome sequences of the virus were released publicly. So it just shows the power of science and technology today. And as I said, these are easier to design and manufacture, scale up as well. Now, having said so, it would be an amazing technological advance, not just for this pandemic, but I think for the future, mRNA vaccines would have a big role to play, I think, in other infectious diseases and potentially non-infectious diseases as well. Now, having said that, this is the first time there's human introduction. So far, and again, with very limited follow-up data of a couple of months, there haven't been major safety signals, so that's very good news. But I think it's really important that these vaccines, when they're rolled out, they must be accompanied by a proper safety monitoring system, what we call a pharmacovigilance system, looking for both expected and unexpected side effects, because quite sometimes you find side effects only when the vaccine has been given to tens of thousands or hundreds of thousands of people. So I think we're working with countries now to put in place those systems, and over a period of time, hopefully we'll have enough data to reassure us that these vaccines are indeed safe.
Dr. Soumya Swaminathan, thank you. It's wonderful to speak to you as always. I think it's important to temper our expectations slightly until we have more data, but perhaps the next year will be decisive for all of our lives. Thank you very much indeed for being with us.